Good morning, everyone. Good morning. We're going to go ahead and get started. Thank you so much for being here. My name is Sarah Dash, and I'm honored to be here on behalf of the Alliance for Health Policy. We're really grateful for the opportunity to bring you today's summit on what's next for social determinants of health. Part of our signature series, which we created 3 years ago to bring you the cutting edge and freshest perspectives on the most pressing health policy issues of our time. We at the Alliance have been hearing over and over again from you in our audience and from our panelists speaking on a variety of topics about just how important social determinants of health are to solving a number of problems in the healthcare system, and just how important it is for us in health policy and practice to understand how we can move forward in very tangible ways that get beyond the buzzwords. At the core of the Alliance's mission is that we create a nonpartisan, multidisciplinary forum to understand both the facts and the real-world lived experience that is so important to formulating good health policy. Today's agenda was developed after speaking with dozens of health policy experts and leaders from a wide range of backgrounds and perspectives, which is our hallmark. And I also just want to say that every single person in this room today brings a really important perspective to this issue. You're here from the Hill and from multiple federal agencies, public health and medical professions, hospital and health insurance, and employer and technology sectors. Some of you are students, some of you are seasoned professionals, and some of you are even Alliance board members. Thank you for being here, looking for them. I hope that if nothing else, everybody will leave here today having met at least one person that you did not come in with, because we truly believe that building those relationships is what's at the core of allowing us to make progress. So it was over 150 years ago that John Snow, the one known as the father of epidemiology, figured out that a particular water pump in London was transmitting cholera, and needless to say, was causing a lot of suffering and untimely deaths. And that is sometimes sort of a focal point that is used to talk about how our environment affects our health. And of course, there are many more examples and abundant evidence on how our life and socioeconomic circumstances, far beyond the medical system, have profound implications for our health and well-being. And our mission today is to better understand how we can turn this evidence into action. So let's get started. I would like to say thank you to our 2019 Solving for Health Signature Series sponsors, some of whom you will hear from throughout the morning. We'd like to thank our visionary sponsor, Pharma, our innovator sponsors, Anthem and Ascension, and our champion sponsors, Aetna, the Blue Cross Blue Shield Association, Cambia Health Foundation, GlaxoSmithKline, and Kaiser Permanente, and our signature sponsor, the Catholic Health Association of the United States. So to start the morning off, I'd like to invite Courtney Christian, who is Director of Policy and Research for Pharma, to give some brief opening remarks. Thank you, Courtney.
Well, good morning, everyone. Thank you, Sarah, for that introduction. I am Courtney Christian. I'm here representing Pharma, which represents over 30 of the country's leading biopharmaceutical research companies devoted to helping patients live longer, healthier, and more productive lives. Every day, researchers at our companies go into labs looking for innovative treatments and cures to combat chronic illness and the range of complex medical conditions and diseases patients face, in the effort to create medicines that will both improve health outcomes and lead to healthier communities overall. Since 2000, Pharma member companies have invested over $600 billion in the search for innovative treatments and cures, more than $71 billion in 2017 alone. So the biopharmaceutical industry believes that our innovation is for everyone. However, we know well that there are communities across the country that face heightened challenges in benefiting from our innovation, given systematic and long-standing issues with access to care that unfairly worsen depending upon a family's zip code. The Alliance, and many of you in this room, as Sarah has said, have been doing the forward-thinking policy analysis on all facets of social health determinants, from educational, economic, and environmental factors that can adversely influence health outcomes. At Pharma, we are also being intentional and thoughtful about the ways in which our industry can work towards addressing social determinants of health and promoting health equity through evidence-based research and cross-sector partnerships with organizations focused on this work. We will soon be convening a health equity roundtable as we undertake this effort, and we look forward to working with many of you in this room. We also recently launched a Roadmap to Health, which is a mobile health fair program which brings educational tools, resources, and health screenings free of charge to communities in New York. We've partnered with community organizations, faith-based centers, and others to reach communities with these resources and look forward to increasing the availability and outreach efforts more broadly. Now, the Office of Minority Health estimates that health inequality and inability to address social determinants of health cost our healthcare system over $50 billion a year. So it's incumbent upon all of us in here to continue to work toward ways to reduce that cost burden, to do even more critical thinking and analysis to push theory into practice in addressing what's next for social determinants of health. Some of those what's next questions might include whether there's a need for standardization of data collection to better map out where resources and interventions are needed. Can there be better alignment of how infrastructure and resources at the local, state, and federal government levels with community-based care systems? What are the best ways in which to assess the non-medical needs of communities like housing, food insecurity, and transportation? Every community is different and each has its unique set of needs. The esteemed group of panelists you all have here today will surely give perspective to these questions and help us all connect the dots on the path forward. I know if we can harness the power of everyone in this room, government, patient and community advocates, physicians, and biopharmaceutical industry, we can make inroads to addressing and improving health outcomes for everyone. So thank you. I hope you all enjoy the panels and have a good day.
Great, thank you so much, Courtney. Hi again, everyone. So we're now going to turn to the first panel of the summit, and I'm really, really excited about this panel. So a handful of states have a state surgeon general responsible for the development, implementation, and oversight of population health policies and strategies. And we're honored to have with us today two of the pioneer state surgeons general from two very different states, Arkansas and Michigan, to share the lessons they have learned for broader efforts to address social determinants of health. So let me introduce them. First, I am so pleased to introduce the nation's first ever state surgeon general, Dr. Kimberly Don Wisdom, who was appointed by the governor of Michigan in 2003, and she served in that role for over 7 years. And currently, Dr. Wisdom is the Senior Vice President of Community Health and Equity and the Chief Wellness and Diversity Officer at Henry Ford Health System in Detroit. Dr. Wisdom provides strong leadership in diversity, population health, and improving the health of those disproportionately affected by poor health outcomes. So welcome, Dr. Wisdom. You can come on up. Thank you. And next, I'd like to welcome Dr. Joe Thompson, who served as the State Surgeon General for the state of Arkansas from 2005 to 2015. Currently, Dr. Thompson serves as the President and Chief Executive Officer of the Arkansas Center for Health Improvement, where he works at the intersection of clinical care, public health, and health policy. And welcome, Dr. Thompson. All right. And I feel super lucky because I get to moderate this panel. Sorry, the public health student in me is kind of nerding out right now, so I'm excited. Well, thank you so much for being here. And I want to start us off by asking you both, where do you think we are right now in the historical trajectory when we talk about social determinants of health? It seems like the public health community has been, has known for years, even hundreds of years, about the sort of need to address our non-medical factors, but now there seems to be a burgeoning of interest from sort of everyone in the healthcare space. So I wonder if you can kind of comment on where do you see things stand right now?
I'd be glad to start us off. For one, I'd like to really thank you, Sarah, and the Alliance for having me and us here today. This is very exciting. I haven't been on the stage with Joe for several years now. I miss seeing him, but I was so glad when Governor Huckabee appointed him as the second state surgeon general. So there were two of us, and so very exciting. I think we're at a major inflection point in terms of healthcare. where the model regarding payment reform and healthcare delivery and understanding that we really need to align things much differently than we have in the past for cost containment reasons and so forth, that we're at this point where I think many people are really understanding the tremendous value of those social determinants and those wraparound services or those social needs, and addressing those in a very deliberate, intentional way. 30 years ago, 40 years ago, when some of us were training, it was clear, practicing in the emergency department for 20 years, it was very clear that there were a lot of social needs that were unmet, and that we were only addressing sort of the tip of the iceberg, applying the clinical model. We saw people didn't have a home to go to, they didn't have a refrigerator to put their insulin in. We knew there were they didn't have transportation home, so we were getting them cab vouchers to wherever they were going to go. They were couch homeless. So as an ED physician, seeing, being on the front line, it was very clear decades ago that there were major issues. But now I think it's received the attention of many people, policymakers, that healthcare professionals, that we're not going to really move the needle in terms of improving health outcomes if we don't address those social needs and ultimately create an arena where social determinants of health can be addressed.
I think I want to echo also thanks to the Alliance and their sponsors, but also to each of you for being here, because I think we're at the beginning of a very important set of conversations. And I say set because I think you can feel it starting in the political discourse about the upcoming presidential campaign. I think you can feel it on the opposite end in health plan management decisions about how to help families that have specific needs. And what we have not done yet is in the middle actually provide a concrete framework for how we're going to discuss this. And let me go there just for a second. The World Health Organization defines social determinants of health as the conditions in which are environmental that affect somebody who's born, who works, who ages, and who goes forward. That's an environmental risk. Those risks, the social determinants of health, end up influencing a family's social needs. And some families do better than others with social needs, and those needs can evolve into a social risk that impacts their health. What we're seeing is health plans recognize that they have to deal with the risk. If somebody doesn't have an air conditioner, the most common example, and they're going to the ER all the time, let's buy them an air conditioner. That's an individual social risk because of poverty, because of education, because of housing, and so forth. But that's not dealing with the community's social determinants. We've got to frame this. I think we've got social determinants on one end where we are starting to have a conversation. We've got individuals with social risks that health plans are starting to engage with. The boundary and the framework, we don't yet have a solid platform with which to have a concrete discussion, and this is one more contribution to that today. Thank you.
Thank you. So you talked about this, kind of continuum between individual risk, the person who doesn't have a ride home from the doctor or the hospital, and then the community-wide risk, right? Like that pump that's transmitting the cholera. How do you begin to bridge that gap?
So I had the opportunity to work directly with two governors. The roles of the state surgeons general are somewhat different depending on the states. Mine, I had no authority whatsoever, but I had the ear of the governor over all of the cabinet agencies that dealt with health or other issues. It was a fun job. I wouldn't recommend that on your future negotiation as Surgeon General, you take those characteristics of the job. Because what happened, neither of my governors that I worked for, and I don't know but of one or two governors that want to be a health care governor. It is too sticky, it is too complex. You share, issues with the federal government, you share issues with the private sector. It is not like, highways where you can pour concrete and run on it the next time that you're actually up for election. But neither of my governors were health governors. When a problem would come, they would say, "Joe, fix this." Okay, I got tired of the phone calls. "Joe, fix this." It was sometimes in the healthcare sector. I mean, we were the first southern state to actually figure out a way to use the Obamacare dollars for Medicaid expansion. But most of the time, it was a community issue. It was a poverty issue. It was a transportation issue. It was an isolation issue. It's the parts of our rural state that are increasingly disengaged by a digital divide because they don't have broadband. All of these things are growing contributions to the social determinants of health for those individuals. And I think we've made some progress. Some of it is governmental, stepping forward. The governor put, not the governor that those two, but the recent governor, the current governor, put coding requirements in the educational curriculum for all high school students to try to get ahead of what the next digital divide is going to be for understanding on the education side. We've got broadband, at least to the hospitals statewide in the state. And we've got private sector opportunities in that Murphy Oil in El Dorado promised to pay for college education for any high school graduate of the public high school in El Dorado. So these are upstream investments, small but important, that I think are examples of things that will pay off dividends downstream on social needs.
Another area where the gap can be closed is, we've talked about partnerships, certainly in the public health arena for a very long time. And I think having more deliberate, intentional partnerships is going to be key, because we know no one sector can accomplish this alone. So one arena around partnerships is anchor organizations. So whether they're healthcare systems, universities, even major businesses in the community, how can those anchor institutions come together in a very deliberate way in order to affect change? So through the Democracy Collaborative, we've been involved at Henry Ford Health System in an effort called the Healthcare Anchor Network. And it consists of 43 different entities that are addressing healthcare in one form or another. So we're looking at best practices collectively as a learning community in terms of how we can address local purchasing, local hiring, as well as local investing. So local hiring, when you talk about social determinants of health, if people have employment and have a livable wage that they can earn, and not have to have a tremendous amount of skills, such as a bachelor's or a master's degree, that provides an opportunity where social determinants of health can be sort of addressed from the inside out by providing that opportunity and creating that environment, as Dr. Thompson has mentioned, that where social needs can be met. Social needs can be met through addressing an environment that supports, and jobs are key. I mean, clean air, those sorts of things are very important. But if our community if they don't have jobs, they don't have the ability to obtain housing that's affordable and safe and adequate, and then food. So all of these things, sort of that whole Maslow's hierarchy of needs that all of us learned about, it's like we're operationalizing, and now having that opportunity to operationalize Maslow's hierarchy in a very deliberate partnership way to affect change.
Great, thank you. So I just want to continue on that partnership theme for a minute. I mean, what does it take to bring those partners to the table? Is it, are you finding people are more attuned and more willing to come to the table for these kinds of partnerships? What does it take to sustain them? Can you say a little bit more about that? Because we're all about tangible steps in this summit.
Right, I can absolutely address that. The partnership through the Healthcare Anchor Network, that is an organization that brings us together, and then we learn from each other. But what we've done in terms of partnerships actually in the Detroit region was we formed to address the appallingly high infant mortality rate in our city. 150 to 200 babies die per year before their first birthday. And we have 4 major tertiary quaternary healthcare systems in our community. So we put together the Detroit Regional Infant Mortality Reduction Task Force. And what's interesting is a task force that consists of 4 competing hospitals or health systems. And so it's sort of this cooperation or collaboration, or where you collaborate and compete at the same time. So it's these unusual partnerships that we're finding we have to bring together. We can't have silos within our communities because patients are, or the residents, the consumers are ultimately adversely impacted. So we've come together with the 4 health systems, state and local health departments, as well as community-based partners and academia, and developed this task force that's been in existence for 11 years. RWJF, Kellogg, and Kresge funded it, and the RWJF program officer would visit us, and she would say, "I can't believe you guys are still working together." I mean, this was an experiment to see whether competing organizations could stay together, work together, and we've been working together for now 11 years. So those unusual the power of some of those unprecedented or unusual collaborations are going to be important if we're truly going to move forward as a region, state, and a country.
I would just build on Kimberly's statements, and for those of you that are change agents, I'm going to go a little pragmatic. People come together that don't know each other because of either threats or opportunities. Threats or opportunities, it's pretty simple. And the way you position that, it can be both at the same time, it can be one or the other, but the way you use data, the way you use articulation, the way you use their language to actually bring people together to say, this is something we need to work on together, is how you build those coalitions of disparate parties to work together. Yeah, whether it's the effect of the financing on the healthcare system that represents a threat, or whether it's the opportunity for future economic development, which represents an opportunity, the social determinant framework, discussion, dialogue, language can fit into both of those. And I think it is a conversation that is starting to happen in places. It's a recognition, and let me back up just a half a step. For 50 years, we've thought medical care is going to fix us when we get sick. I think we were finally, over the last decade and a half, recognizing it doesn't work that way. Okay? Medical care is going to keep us from maybe having disability, maybe from dying early, but it's not going to keep us healthy, productive, having high-quality life in the way that we envisioned it. Mm-hmm. And so people are asking the question. They feel that threat. They're asking the question, why is that? And there's increasingly a volume of data that's available to suggest why. And now those conversations are having to come together for the possibility of having opportunities to do things differently.
So I want to talk about that question of access to medical care, because notwithstanding all of the non-medical factors that are out there, we've recently seen some data around access to the Medicaid program actually reducing some pretty significant disparities, racial disparities in cancer and in other formats. So can you talk about that, like as Surgeon Generals, or even in your current role, how have you seen that play out?
I'll start off, and I'll go back to the World Health Organization's definition of social determinants. Those things that it defines as social determinants, it also explicitly calls out are caused by misallocation or a differentiation in power, resources, and influence. Well, the Affordable Care Act, in its expansion of coverage, dealt with distribution of resources and income to a certain extent, to the extent that individuals were expected to pay part of their income for insurance. Power, resources, income. That means we're going to be addressing issues of low-income communities and communities of color. And so the Affordable Care Act was a single policy impact that differentially affected low-income communities and communities of color, and I think we're starting to see the evidence show that that made a difference. I think rationally we all thought it would make a difference, but I think the fact that people are looking, seeing, finding mortality differences by race because of income expansion for low-income individuals in communities of color and low-income communities, we need to amplify because it shows the difference that can be made.
Right. I'm going to give a little different twist, and thank you for that, Joe, in terms of the access element, because there's sort of a myth that you build it and they will come. And so if we provide long-acting reversible contraceptives, for example, or other services and provide access, that people will avail themselves to those resources. And that's not necessarily true. I think understanding the community deeply, understanding the challenges, the fears, the concern, and also understanding how people may be welcomed or maybe not as welcomed by healthcare professionals. Now, I know, those of us, in healthcare providing direct services, physicians, mid-level providers, nurses, that sort of thing, we went into the profession to truly help people receive the best health outcome, or certainly healthcare outcome that they could. However, I think in many instances, we aren't as welcoming to communities. We don't provide as much, give them as much of a dignified experience as possible. So I know it's a little different twist, but we're finding in a lot of the work that we're doing that we have for our disenfranchised, marginalized communities, we've kind of done a disservice at times in terms of access because we scold people, we criticize them when they come in for care. It doesn't engender trust. Then we wonder why they're do not shows. I mean, in the past, back in the day, we used to stamp DNS on the paper chart when patients didn't show up. And I was troubled by that. And then I started going out into the community, into the faith-based organizations, and saying, why aren't you showing up? Well, when you go to the church, after church, there would be 10 people waiting in line with a brown bag of medications because they wanted a consultation from you, yet they're the same people that are the do not shows in the clinic. So I think access, we really need to think about what that word access means. Affordable Care those sorts of things are very, very important and critical and foundational. But I think also when we think about access, we have to think about it in a different way to ensure that we're providing the best access for a diverse population in order for them to receive the care that they need and the way that they need it. Just one other statement. In the past, when I was training in medical school, we said we treat everybody the same. We were very proud of that fact that we treated all of our patients the same. Then we sort of evolved to this place where we treat patients, community members, the way that we want to be treated. Well, that's kind of a little bit egocentric. And then now we've evolved to the place where we treat you the way that you want to be treated. We provide a care in a way that's it provides a great experience for you. So the beauty of medicine is we continue to evolve and learn and grow, but I think we need to think about access in ways to ensure that we provide a welcoming setting and a non-judgmental environment for those that we truly want to serve and to close those health disparities gaps in that way also.
Thank you.
If I could just build, Kim, I mean, I think you're absolutely right on having a culturally competent and receptive workforce. I mean, along, cultural or racial and ethnic perspective. For all of you in the audience, I think it's important to think broadly. The rural parts of America, the business model for healthcare is non-viable. Okay, it is not going to be there unless we come up with a different pattern. It will affect everybody who's in that community, and it will affect those at risk the most in that community because they won't be able to leave to get health care in another place. So I really do think it's time to reboot. It's like hitting your computer button and reboot because you got too many programs open. Let's reboot it. Think about what we know and actually think about what we would design. We're not going to be able to erase what we have, but we can start moving towards a North Star to recognize what it's going to take to achieve the equity that we want to have for the nation.
Exactly. And I just want to follow up on that. What is a first step? How can health systems, take that step to meeting people where they are and where they would like to be met, and to truly, we talk a lot about the word patient-centered.
Sure.
But how does that happen in a truly equitable way? And
Sure.
and like what have you found? I mean, that's a huge shift that you just talked about, from treating everyone the same to treating people how they would like to be.
Sure. There are various frameworks out there, and I just let me just mention one that's kind of in a research context, the community-based participatory research methodology approach. And it's where truly you listen to the community. And as healthcare professionals, we didn't necessarily have to. We were fee-for-service, we weren't value-based, and so we could we're there, you have to come, you have to receive services, we bill and move forward. However, now I think the onus is upon us to really listen to the community, to really hear what they're saying and shape things based on what their needs are and what they're saying. So let me just give tangible, I like to give tangible examples as often as possible. So we wanted to address infant mortality reduction in the city of Detroit. So we wrote a grant, it's called Sew Up the Safety Net for Women and Children. The reason why we called it Sew Up the Safety Net is we did an inventory. So here we have this high infant mortality rate, and we did an inventory of all of our partners. We found there were over 100 programs that addressed the needs of women, children, and many of the programs were undersubscribed or at risk for losing funding. So here, 100 programs and underserved women. So we thought we'd sew up the safety net. So we called it Sew Up the Safety Net for Women and Children. RWJF, they understood that. The funders, they loved it. We loved it. We thought, we're in good shape. Lo and behold, we go to roll it out into the community, and the women said, sew up the safety net. What is that? What are you sewing up, for one? Are we slipping through some cracks? And, what does this mean? So we brought them in and had a lot of focus groups. Here, we thought we were really approaching this work in a way that was, culturally appropriate. And long story short, after the focus groups, we analyzed the data, we talked to the women, we engaged them, engaged our community health workers, which is another key model. We ended up changing the name to WIN Network Detroit, or Women Inspired Neighborhood Network Detroit. They said, we're resilient, we're resourceful, we're keepers of the community. So we were using the deficit-based model as opposed to an asset-based model. So listening. The answers are there, but you have to listen to the people that have the answers, and those are the people that we're trying to serve.
Thank you.
Yeah, I think the healthcare system needs to meet the person from where they're coming. It's frequent, we have a specialty clinic, but the person doesn't just have that one condition. They have multiple chronic conditions. And so I think meeting the person from where they're coming and doing it in an intellectually honest way. Systems, clinics, ERs are increasingly adding screeners for social needs and social risks. But let me tell you how you can step off in the ditch quickly. So pediatric emergency department trying to screen for food insecurity. So they're asking a parent in front of their child, how many days out of the month do you not know where your food's coming from? Do you in front of your child want to admit that you don't know where food's coming from 15 out of the next 30 days? No, we've got to think about this in a way that's incredibly, thoughtful. It's ways that we've never asked questions before, but we're starting to reach out and meet the person with where they're coming from to try to understand their holistic needs, not just their medical care issue itself,
Right.
Because that's where we get non-compliance.
Right. And to that point, we actually have, Joe, you make it a great point, that we have community health workers that actually are asking those questions. And in many instances, we have them asking those questions in the home where possible. I mean, of course, in the clinical setting, it's necessary if you don't have the ability to do home visits. But we ask, just like a physician, a patient will tell a physician one thing, then the nurse comes in to discharge a patient, and you hear another whole scenario. I know nobody's experienced that but me, but it's like the nurse or the other healthcare professional sometimes get a better story than you as a healthcare professional. We find the community health workers get a much better and accurate, are able to collect that data much more accurately because they can walk in the home. If there's not a refrigerator there, that's probably a clue that there's some other serious challenges going on. And we have to preserve people's dignity. And so patients misrepresent themselves not because they want to, but because their dignity needs to be preserved. So when we're able to go into a home setting or have a community health worker who's maybe kind of at a similar socioeconomic level that they are, then we'll get the real information, and then we can take real action in a very dignified yet deliberate way.
So we've been talking a lot about how to reach people and communities. How do we reach leaders, political leaders, other, you both are obviously great leaders. How do you reach other leaders with this message that, that there needs to be sort of a different way of doing things around social determinants of health?
So first, you be prepared, because you never know when the policy window is going to open, and that you can put a message in place that's a seed that plants and that grows over time and becomes a tree. So thank you for being here today. You're on your path to being prepared. The second is, I think you've got to engage. There are leaders who have challenges that aren't your issue, but they need help. And so you can actually engage with them to establish a relationship. I knew neither of the two governors before I worked for them. Had not contributed to a campaign, had not worked on their campaign, they wouldn't know me from Adam, and yet the door cracked open. They had an issue that I could help them with, and then the relationship evolved and developed. And I'll share with you my experience with these two leaders, and I share it intentionally because many of you will have similar experiences. There's a trust that comes with that relationship that builds over time. And with both of these guys, it was 3 phases. The first phase, whenever they had a question, I would come in with 3 options and have the pros and the cons for all 3 options, and it would be the full spectrum of, from things that were far right to things that were far left and things in the middle. and they would pick which option they wanted to pursue. Second phase is you're bringing 3 options, and they ask you, which one do you think is the right one? Okay, they know you've got the 3 options, you've thought through the pros and the cons, and they're asking which is the right one. Third phase in the relationship is you just get to bring the option you think is the right one because they trust that you have the 3. If they don't like it, you better have the 3 because you better have the backup. But in this trust and relationship, I think there is a personal conversation with leaders. I think there's an investment in time. I think it is not a straight path. It's a zigzaggy path based upon external influences and other things. But I think, again, the conversation around social determinants is growing. It's not clear. It's not building highways. Where are we going to put exit number 36? It's actually complex, and our leaders are starting to ask questions. As they start to ask questions, be attentive for what the question sounds like. I have never yet had any elected leader say the word social determinants of health. I use the term zip code risk, and the light bulb goes off. They're like, okay, that makes sense. I mean, I've got health behaviors, whether I use tobacco, physically active, that's, personal health behaviors. And then I've got zip code risk. And I can be doing perfect on health behaviors, but zip code matters.
Right.
I've got a 10-year age-adjusted mortality difference from the southeastern part of the state to the northwestern part of the state, which is 300 miles. 10 years. That's aggregate. If we go into micro data, it's 15 to 18 years difference. If the door cracks open and the conversations happen, that's when you plant the seed, and that's when the conversation develops into policy opportunities.
Yep.
And as you respond, if you don't mind talking about a little, do you think that more states will appoint Surgeon General? We have about a handful now in some other states.
Absolutely,
but, yeah.
and thanks for asking that. So it kind of dovetails with the previous question. I think being strategic and opportunistic is the approach that oftentimes, so being prepared. So an example of hopefully some level of preparation, 16 years ago I was appointed as Michigan Surgeon General, a long time ago, but from day one I was on this journey, and Joe probably remembers hearing me talk about it at some of the dinners and that we went to. Every state, I would love to see every state and territory have the opportunity to have a state-level Surgeon General. So they're like, yeah, Wisdom, fine. And so we wrote a case study, and then ultimately we wrote a white paper. Then most recently, actually 3 years ago, an issue brief came out from, we worked with the National Academy of State Health Policy to an issue brief regarding all 4 states that had a state-level Surgeon General at the time. So that is set on the shelf. Huffington Post blogged about it, but basically it's gotten dusty for the last 3 years. Then lo and behold, most recently California appointed their first state Surgeon General. That's where preparation meets hopefully this great opportunity of now developing an effort where we can collectively develop a roadmap for how other states can embrace the state Surgeon General, because it's often said as California goes, so the country goes. At least that's what the Californians say. I'm from Michigan, but I feel very hopeful if there's any state. Like I said, Joe's was the second, and I had great conversation with Governor Huckabee about please appoint Joe. I don't know if you knew that, but anyway, I did. And but if we can develop this roadmap where every state that can then perhaps have a turnkey ability to appoint a state-level Surgeon General, that would be a way to structurally address health and healthcare disparities, but also very deliberately social determinants of health.
Okay.
Let me build, Kimberly and I may be a little different. Surgeon General is a title, right? It's what the activity is that's the important piece. Most state agency heads, most federal agency heads, they're going from crisis to crisis to crisis. They don't have the time to think about strategy, about, okay, what is causing these crises that are happening each day? And I think that's really where state leadership, executive branch leadership benefits from having somebody that actually is looking at the upstream causes as opposed to dealing with the downstream crises.
Exactly.
And states that recognize that need, I think, will adopt the model of the Surgeon General.
And you were a great strategist in terms of your state, and lauded for that. So having that ability to have that advisory, strategic, advocate position is really key because, like you
And
said.
being willing to say, I don't know. Don't get out there where you think you know and you don't know, because this is going to be complex going forward.
Well, thank you both. I wish we could talk all morning, but we have a fantastic agenda ahead of us. So, Joe, Kimberly, Don, I want to thank you both so much for joining us this morning.
Thank you.
Thank
Thank you
you.
for having us.
Thank you.
Thank you for being here.